Welcome to The Explainer. Today, we're going deep on a silent threat, a reservoir of tuberculosis that's hiding in plain sight. We're talking about latent TB infection. It affects a truly staggering number of people, and honestly, it's one of the most critical fronts in the global fight to eliminate TB for good. Okay, let's just let this sink in for a second. 1/4, 1 out of every 4 people on this planet is estimated to have latent tuberculosis infection. We call it LTBI. That creates this enormous, invisible pool of potential TB, just waiting for a chance to become active disease.
So here's our game plan. Think of it like a public health containment mission. We'll start with the hidden reservoir itself, figure out how to detect this latent infection, and then talk about inferring pathogen susceptibility. From there, we'll dive into modern prophylactic regimens, touch on public health and control, and wrap up with the clinical risk calculus.
All right, first up, the hidden reservoir. We really need to get our heads around this immunological stalemate that's happening inside the body.
Yeah, this is so important. We can't think of LTBI as the bacteria just being asleep. It's not dormant. It's an active, ongoing standoff, a really delicate equilibrium between your immune system and the Mycobacterium tuberculosis bacteria. And the main stage for this whole battle? It's a tiny microscopic structure called the granuloma.
The granuloma, it's the absolute hallmark of TB. Your body builds this little fortress, the structured wall, to try and contain the bacteria. But here's the wild part. It's a total paradox. The bacterium is actually hijacking the process, manipulating your own cells to make sure this little prison is built just right for its own long-term survival. It's an incredibly smart pathogen.
Okay, so if this whole thing is hidden away, how in the world do we find it? Let's talk about detecting the latent infection, about separating the signal from the noise.
So we have 2 main tools, and the difference really comes down to precision. You've got the old-school tuberculin skin test, the TST. It uses this, kind of crude mix of over 200 antigens. The big problem? It can cross-react with the BCG vaccine, leading to false positives. Then you have the modern approach, IGRAs. These are blood tests, and they are way more specific. They look for a response to antigens that are only found in Mycobacterium tuberculosis, so they aren't thrown off by BCG at all. Much cleaner signal.
And this is probably one of the most critical takeaways. A positive test, I don't care if it's a TST or an IGRA, does not mean someone has latent TB. All it tells you is that their immune system has seen TB bacteria before. It gives you 0 information about whether it's latent or active contagious disease.
And that is why this diagnostic algorithm is absolutely non-negotiable. You get a positive test? Fine, step 1. But then you must do a thorough symptom screen and get a chest x-ray. Only, and I mean only, if the person has 0 symptoms and a clear chest x-ray can you make the diagnosis of LTBI. Because if you mess this up, if you give LTBI treatment to someone with active TB, you're not just making a mistake, you're potentially creating drug resistance. It's a huge deal.
Okay, next puzzle. How do we choose the right drugs? We can't just grow the bacteria from someone with latent TB to see what kills it. So we have to get clever. We have to infer its susceptibility.
This is where clinical medicine and public health epidemiology just have to work hand in glove. The idea of inferred susceptibility means we're making an educated guess. If we know who the source case was, the person who transmitted the infection, we look at their lab results, what drugs worked on them. If we don't know the source, we have to rely on local public health data about what drug resistance patterns look like in the community. It's all about detective work.
Now this is where things get really serious. If someone's been exposed to drug-resistant TB, you can't just throw the standard playbook at them. It's worse than useless. It's dangerous. It gives a false sense of security while the resistant bug just hangs out. The therapy has to be tailored to the specific resistance profile of the source case. And honestly, this is not a situation for guesswork. You must, it is absolutely mandatory to consult with a TB expert or the public health department.
Okay, so now for some really good news. Let's talk about the actual treatment, the modern prophylactic regimens. This is where we've seen a huge paradigm shift away from these long, painful treatments toward shorter, more effective precision strikes.
So if you look at the preferred options today, you'll see a theme. They're shorter, and they're based on a class of drugs called rifamycins. We've got great choices like 3-HP, which is isoniazid plus rifapentine once a week for 3 months, or 4R, which is 4 months of daily rifampin. These are just so much better tolerated and have way higher completion rates than the old standard, which was 9 long months of isoniazid.
All right, let's work through a scenario. This one is super high stakes. You have a 2-year-old child who's been exposed to someone with active TB. You test the child, and the test comes back negative. So, what do you do? The answer here is a bit counterintuitive, but it's absolutely critical.
What you do is start treatment anyway. This strategy is called window prophylaxis. Think of it as a preemptive strike. See, in a very young child, it can take 8 to 10 weeks after exposure for their immune system to mount a response that you can even detect with the test. We can't afford to wait that long. The risk of them developing a severe form of TB, like TB meningitis, during that window period is just too high. So we treat. And this really gets to the heart of it all. In a young child exposed to tuberculosis, we treat the risk, not the test. It's such a powerful way to frame it. The risk of doing nothing is potentially catastrophic. The risk of giving a short course of medicine that maybe turns out not to have been needed, that risk is tiny. It's a no-brainer.
Okay, let's zoom out a bit. We've talked about the individual patient, now let's think about public health and control at the population level.
You know, there's an old saying, you can't manage what you don't measure. And that is a huge problem with LTBI. Take the United States, for instance. Reporting is this messy patchwork of different state laws, so we have a really incomplete picture of what's going on. Then you look at a place like the Netherlands, where they've had a nationwide register for decades. That kind of robust data is absolutely essential for monitoring and for knowing if your programs are even working.
And just to be crystal clear on this point, someone with latent TB infection is not infectious. They can't spread it to anyone else. The bacteria are walled off in those granulomas. The best, and really the only, infection control measure for LTBI is to treat it, to prevent it from ever becoming active and infectious in the first place.
So this all comes down to what we call the clinical risk calculus. It's about weighing the pros and cons, the risk of doing something versus the risk of doing nothing. Here's the basic trade-off. On one hand, you have the risk of inaction. If you don't treat the LTBI, there's a chance it progresses to active contagious TB disease. For a healthy person, that lifetime risk is somewhere around 5 to 10%. On the other hand, you have the risk of action. The treatment itself can have side effects, with the most serious being liver toxicity. So you're always balancing these two potential outcomes. And this chart really shows you how that risk calculation can change dramatically depending on the person. Look at this. For someone who is also living with HIV, their risk of that latent TB reactivating isn't 5 to 10% over their whole life. It's a jaw-dropping 7 to 10% per year, every single year. When the risk is that high, the calculus becomes incredibly simple. Treatment isn't just a good idea, it's an absolute urgent imperative.
So, that kind of leaves us with this final big question. We have the tools now. We have these effective, short-course regimens that work. They're like precision-guided missiles against latent TB. But is the biggest hurdle we face really about pharmacology anymore? Or is it about our failure to consistently measure, track, and manage this enormous latent reservoir? We have the weapons, but do we have the public health infrastructure to actually deploy them to the millions upon millions who need them?